Welcome, friends of the Retinal Channel podcast, to another episode of this series. My name is Dr. Kivan Kushan. I'm very excited to bring you this episode today with my guest, Dr. Mohsin Ali from Washington, D.C., who has done this very neat study on clinical examination for affirming presence of a posterior vitreous detachment or a PVD. This is something that I've been teaching my residents to try to do using the Slit-Lamp without use of lenses to see if there's PVD present or not versus observing a Weiss ring, as we say. And Dr. Ali and his colleagues have done a prospective study to see if this method of using the slit lamp can actually be better than traditional method of using the Weiss ring to confirm presence of a PVD. I thought it's a very neat study, and I'm happy he did that. Dr. Ali is one of our colleagues from Washington, D.C. He practices in the retinal group of Washington and Georgetown University School of Medicine. He's a co-director of the vitreoretinal surgery fellowship training program there. He did his ophthalmology residency at the University of Illinois at Chicago, and also his retina surgery fellowship at Duke University. So I'm very honored that he accepted my invitation to join the Retina Channel podcast and give us his wonderful, very neat study on affirming presence of a PVD. Well, without further ado, this is Dr. Ali.
Hello.
Hello, Dr. Ali. Welcome to the Retina
Good.
Channel podcast.
Thank you. Thank you. It's very nice to be with you. So
Well,
you're in Canada right now? Is that right?
yeah. I'm in
Okay.
Toronto. I'm based in Toronto. Yeah. We
Very
have
good.
had a lot of snow this year. How about you folks in Washington, D.C.? How's the weather there?
Just a little bit of snow here and there, but of course, 2 inches of snow will shut down the whole city and cancel
Is that
school.
right? Is that
So
right? Okay.
yes,
Okay.
we
Okay.
are we are very wimpy when it comes to the snow.
Oh, okay. Okay. No, we've had
Yeah.
a lot of snow this year. For skiers, this is a good year, so
Nice.
yeah.
Nice.
Very good.
Well,
Well, I appreciate you being here.
absolutely.
I read your article and I loved it. It's one of those neat things that, that I've been teaching my residents all the time, but no one actually had taught me. I discovered this method by accident myself when I was like a practicing physician and in my practice. And you obviously picked it up and you did nice research on it. If that's okay with you, I'm going to go over that for the listeners and the viewers. It's a prospective
Hmm.
study. You picked up 206 eyes, quite a number of eyes, and you have
Yes.
two assessors. I think you were one of the assessors, and you looked at the presence of Weiss ring versus presence of your method of using a slit lamp for determining
Hmm.
PVD. And you had sort of a gold standard of OCT to see if the PVD was actually present or not, and then
Exactly.
you compared your two methods versus the gold standard. And I think your method of using the slit lamp showed up a bit more sensitive than Weiss ring, which was very interesting to me. So if that's all right, tell me how you came up with this idea. What triggered your interest in doing this work?
Well, Dr. Kushan, that's a very good question because just like you, I also stumbled upon this technique. I kept racking my brain afterwards, wondering who is it that taught me this? And
Yeah,
then I've asked other people, other retina specialists. Many retina specialists actually don't even know about this technique when I've
yeah,
inquired about it. I would say the
I believe.
majority.
Yeah,
And then residents, of course, don't. When you find someone else who knows about this technique, either they stumbled upon it themselves,
hmm,
or a very senior, close to retirement age ophthalmologist or retina specialist taught them this technique. So it's an old technique that I think only gets passed down from one mentor to one of their students. Has not been written down very extensively. It's not in our textbooks like the BCSC. If
yeah,
you go online, you won't be able to find anything about it. So when I came to start utilizing it, I realized that I found it to be extremely effective. And in
yeah.
my personal opinion, I found it to be more reliable than even the Weiss ring method, just in terms of my examination skills. And
Mhm.
so that's when I decided, hey, we really need to describe this a little bit more and identify whether it's a useful diagnostic skill that we need to teach other people about. And so that's the genesis of why this project came together.
Fantastic. And how long you've been in practice, if I may ask?
6.5 years now.
So 6.5. So you discovered that in the past 6.5 years that you've been. So this is something you picked up as an attending yourself.
Yeah, like I said, I still am racking my brain trying to figure out whether I came across this in residency or in fellowship, but and I don't know. But when I actually began to use it more regularly, it was definitely post fellowship as an attending.
Same for me. So I picked it up on my own, by accident, and then said, "Oh, this is so neat," and I started teaching it to residents. Like, very interesting. So let's talk about it. Before we talk about your study, let's talk about this method. Is Could you, in sort of say someone as a retina specialist or a resident or a fellow listening to this podcast wants to know what you're talking about? Could you maybe describe what is it you're talking about? This clinical exam method using just a slit lamp.
Yes, absolutely. So, first of all, I think sometimes it's better to just watch a video of it.
Mm-hmm.
So, if you go to the ophthalmology retina website where you can access the study, there is an accompanying video that shows the actual technique being performed, and you can actually visualize the posterior vitreous cortex or the posterior hyaloid face or the posterior hyaloid membrane, whatever term you want to use.
Mm-hmm.
And that I think is the most the easiest way to get your head around what it is that we're describing. And if someone needs that video and can't get access to it behind the paywall, you can always email me and I can send it to you. But basically, I think that it's important, first of all, to kind of understand what it is that we're talking about when we refer to what we're describing in the paper as the posterior hyaloid membrane. As most vitreoretinal surgeons already know, when a posterior vitreous detachment is occurring, it is the culmination of multiple anatomic changes within the vitreous body itself. So there is liquefaction of the vitreous and then condensation of collagen fibrils. So initially, um, if you look example for into my eye right now, you will see vitreous collagenous fibrils clumped together. In 10 years, you might start seeing lacunae or liquefied pockets in
Mm-hmm.
my vitreous body. And then eventually, like the majority of us, those liquefied lacunae and the liquefied vitreous will penetrate through little microscopic openings in the posterior vitreous cortex. And then you have liquefied vitreous entering into the subhyaloid space. And then in vitreous retinal surgery terminology, hydrodissecting, you can say, the posterior vitreous cortex from the retinal surface.
Mm-hmm.
So all of these things you can visualize. You can visualize syneretic vitreous. You can visualize lacunae. And then ultimately, you can visualize the actual posterior vitreous cortex when
Mm-hmm.
you look with the slit lamp. We have termed this the posterior hyaloid membrane. There are people that may take exception to that terminology because it's not a true membrane in the sense that it doesn't have type 4 collagen, etc. But let's leave behind the histopathology here.
Mm-hmm.
Uh, we are talking about a membrane-like appearance.
Or a face,
So,
some people call it. Posterior face.
yes, posterior
Yeah.
hyaloid face, yes. So let's say you're at the slit lamp. You will uh, try to follow the following steps. First of all, you arrange the patient in a typical manner that you would do for any uh, fundus examination, but you have to be very particular when you're trying to examine the posterior hyaloid membrane. So you want to make sure that they're, first of all, adequately dilated. In
Mm-hmm.
my hands, based on this study, I would say that you're going to have your best bet if the patient is dilated more than about 5.5 millimeters.
Mm-hmm.
So adequate pupillary dilation. And then you want the room lights darkened, just like you would if you were looking for cell or flare in a uveitic patient. You really want to have the room lights completely darkened as much as you can. And then very importantly, you need the patient's forehead up against the strap. The reason
Mm-hmm.
you need to do this is because you're going to be directing the slit lamp beam very posteriorly. So if the
Mm-hmm.
patient is not anterior enough, forehead against the strap, you're not going to be able to reach the light beam posteriorly enough. So that's very, very critical.
Mm-hmm.
And then you want to have the patient, just like you would if you were examining their optic nerve, look at your opposite ear. And
Mm-hmm.
then you want to keep the intensity of the beam of light at its highest. So take the neutral density filter off, again, just like you were looking for cell and flare.
Mm-hmm.
And then I like to make the slit lamp beam height around the height of the pupil.
Mm-hmm.
So it has to be long enough, or tall enough, I should say. And then you take the beam of light and you make an optical section with it, or you basically have an off axis illumination. And then you start directing the beam of light posteriorly. So go to the lens, just like you would when you're examining for nuclear sclerosis, and then keep going more posteriorly.
Mm-hmm.
At that point, you will find yourself looking at synovitic vitreous.
Mm-hmm.
And then you keep going more posterior to that. And at that point, that's when you're in the region where you might start seeing the posterior hyaloid membrane if it's visible.
Mm-hmm.
And what you're looking for um, is this continuously hyperreflective, silvery colored line
Mm-hmm.
that has a almost ribbon-like or serpentine-like billowing, undulating shape.
Yes.
And if you look at it with high magnification, this has been described by a doctor out of England, Martin Sneed. Um, you will see little crinkled creases or little folds in it.
Mm-hmm.
But the key is that you really want to, when you're first starting out, look for all of those features of it because it can get a little bit tricky. Because you can also see hyperreflective linear opacities just from synoretic vitreous.
Mm-hmm. Mm-hmm.
And sometimes, if you have a pocket of liquefied vitreous, like a lacunae, posterior to it, you might mistakenly believe that that's the posterior hyaloid membrane.
Mm-hmm.
So you want to make sure you sort of look for all of those features, and then the more you see it, the more you'll be able to almost instantaneously recognize it like pattern recognition. But
Yes.
again, that the other really important thing is that you want to make sure that posterior to it. So once you see the membrane, posterior to it is all liquefied vitreous.
Yeah. It's almost nothing behind it.
Exactly, almost nothing behind it.
Nothing
And
but
everything in front of it is all the syneresis. So if you
yeah.
go posterior and you see the membrane, and then you go posterior and you see another membranous-like thing, that means the first one was not the posterior hyaloid membrane. There
Yes.
should be
Yeah.
nothing but liquefied vitreous posterior to it.
Yeah. Yes. So thank you for the explanation. I sometimes tell the resident it looks like a blanket or sheet. It kind of undulates as you said. And if you go right
Yes,
and left, you can almost trace this blanket. So as opposed to these strands of vitreous that are everywhere, this is like a sheet or a membrane that you can identify. You know,
yes,
but
yes, exactly.
very nice. So maybe that video you just described. I'll put a link in the show notes so people can look it up if
Perfect.
there's no firewall or any paywall for that. Awesome. So for your study, and you have this wonderful discovery, and you put that in the study so people can actually you proved that it actually working. So these people you picked up, 118 people or 206 eyes. how did you pick him up? Did they come to emergency room for PVD symptoms? How did you select these people?
No, actually, these were consecutive patients that I encountered in the retina clinic. So these are not patients that came in for any specific symptoms whatsoever. They're just all the patients I encountered over a
Okay,
period of time.
fair enough.
So that means you have in this cohort patients who have um, macular degeneration, patients who have just follow-ups for posterior vitreous detachments, whatever the case
Yeah.
may be. So not all of them had any known diagnosis really ish, 57.3 to be exact, of the patients had a true posterior vitreous detachment.
Hmm. And then they all had OCT, so retina clinic, they all had OCT. So that was your gold standard for affirming if there is complete PVD or not, correct? So, and you said,
That's right, but with a caveat.
mm-hmm.
Yeah, so the
What's the caveat?
caveat with the OCT is that it's not simply the typical OCT that many retina specialists will use, meaning the central macula. This
Mm-hmm.
OCT includes the whole macula plus the optic nerve
Plus the
head.
nerve. It's a
Because,
longer
as you
OCT. Okay.
know, the longer, yes, exactly. And the
Mm-hmm.
reason for that, as you know, is that when you have the end results or the end stages of the vitreous separation, you will see the vitreous still tethered to the optic nerve head. So if we
Mm-hmm.
did not do that type of OCT, we might be falsely identifying partial vitreous separations as complete
Yes.
vitreous separations. So to do this properly and to truly use OCT as a quote unquote gold standard, um, then you really need to have the optic nerve head included in that scan.
Amazing, amazing. Because someone could
And
argue it may not be the gold standard, but you included the optic nerve to essentially counter that argument. Yeah.
yeah, and the folks that would argue that OCT is not a true gold standard are absolutely correct. The true gold standard is what we're trying to work on next, which is intraoperative assessment
Yeah.
of whether there's a true PVD or not. That's the real gold standard. But obviously, that's a
But
that's a much
sometimes
more
that isn't
difficult thing
hard.
to
And
do.
high myop, sometimes it gets schisis. That isn't becomes a questionable issue. Yeah.
Yes,
But you
yes,
did the
and
best as
that
possible
brings
in the
up another
clinic.
good point.
Yeah. Yeah. Very nice.
Right.
So,
Yeah.
and
This
then you
is
have,
this is
go
the
ahead.
best you could do.
Very
Oh, I
nice.
was going to say the other thing I was going to say um, about the OCT is that uh, there were in this study three separate masked graders of the OCT other than myself. So the person who
Okay.
was grading the examination findings was different than the three masked OCT graders.
Three mask OCD graders. Okay. Okay. Very nice. And did they agree most of the time, those three graders? Or,
Yeah, so we checked that. That's a very good question. And it was about the kappa coefficient to check the correlation or the inter-rater reliability was about 0.95, which is very high for
very,
the inter-rater agreement between the three masked OCT
okay.
examiners.
Okay. And the same eye or same patient also had examination by the slit lamp, the method you just described, and condensing lenses for looking for the Weiss ring. And who did those examinations?
Correct.
And did you do the same
So
examination or
the same
another?
person.
Same person. Okay.
So yes, I did the slit lamp assessment for the posterior hyaloid membrane. And for that portion, I was masked, meaning I did not look at the OCT. I did not have access to the patient chart at that time. It was just going right in there, evaluate. First thing I do, evaluate the posterior hyaloid membrane. Subsequently, for a subset of the patients, not all of them, a subset of the patients, a fellow, vitreoretinal surgery fellow, would do the same posterior hyaloid membrane assessment method to identify that posterior hyaloid to see if there was reasonable inter-rater reliability between myself and someone else in identifying the posterior hyaloid membrane. And that inter-rater reliability in the subset of patients that had both people do it was about 0.88, which technically is still quote unquote excellent. And then after that, I would assess the Weiss ring. So that portion, when I was assessing the Weiss ring, I was a little bit biased because at that point I had already done the posterior hyaloid membrane
It
assessment
was the
method.
same setting, same setup,
Same setup, yeah.
yeah. Okay.
Still not, still haven't seen the OCT,
Okay. Yeah.
um, but
Hmm.
but yeah. And the reason, of course, logistically, it would be very difficult, even though we oftentimes have more than one retina surgeon in the office at the same time, to have 206 patients in a busy retina practice to be checked for a Weiss ring by me and then by another vitreoretinal surgeon
Hmm.
would be logistically impossible.
Hmm. Hmm. And then, so you had one result by your method, result by looking at for the Weiss ring, and then you took the method, these two results, and compared them to your gold standard for this study. And then you looked at,
Yes.
and then you looked at the sensitivity and specificity of these two methods, Weiss ring versus the slit lamp. And what was the results?
So, yes, five parameters: sensitivity, specificity, positive predictive value, negative predictive value, and area under the curve. And basically, if you want to take the most important highlights of that data,
Mm-hmm.
all of them, sensitivity, specificity, positive predictive value, negative predictive value, and area under the curve, were all very high for both methods, but
Mm-hmm.
statistically significantly higher for sensitivity and negative predictive value
Mm-hmm.
for the posterior hyaloid membrane assessment method. So it either equally performed equally to the Weiss ring method or superior to the Weiss ring method in those two things, the sensitivity and the negative predictive value. So just to, for the audience to know what the numbers are, I think sensitivity would be perhaps the number that most people would be interested in.
Mm-hmm.
Um, and it was 89.8% for the posterior hyaloid membrane method and
Very high.
79.7% for the Weiss ring method. And then
Mm-hmm.
area under the curve, if you want to just sort of use that as another method, it was about 0.93 for the posterior hyaloid method, and Weiss ring method was about 0.89. So So I would say both methods are good, but the posterior hyaloid membrane method did outperform the Weiss ring method, and that was what I felt. That was my hypothesis going in.
Mm-hmm.
What do you think? I mean, you're someone who uses it very often. Do you also feel like you
I
sometimes can get
feel
it more
I
reliable?
feel the same. I feel it's more reliable than Weissing. A lot of times Weissing it moves around. You don't see it necessarily in an eye doctor examination. Optos sometimes picks it up better than the eye doctor. Um,
Yeah, true.
Also, I find the slit-lamp method works, especially in people who are myopic. It's easier to pick up in myopic patients. Somehow that sheet of posterior hyaloid face is easier to pick up. But I like it that you showed that negative predictive value was pretty high. That means if I feel there's no PVD based on this Slit-Lamp method, um, I can be more certain there's no PVD. um,
Yes. Yeah.
and
Yeah.
versus
About
if,
87.5, 87.5%.
yeah, and if there is PVD, if I see so it's, if I see a PVD face and I'm certain that's my posterior hyaloid face, I'm almost like completely positive there is PVD. Like when I know I see that wrinkle sheet you were mentioning, I know there is PVD. There's no way around it.
Yes, exactly. So that would be the positive predictive value, and that is about 96.4. But even the Weiss ring in that regard has a very high, about 97.3 for the
Hmm.
positive predictive value. So yeah,
Yeah.
absolutely. The uh, other thing, I don't know what you feel about this, but as someone who teaches trainees, you probably have a good sense of this as well. I feel like when I was a trainee, I would see Weiss rings that weren't truly there
Hmm.
because I would mistake other vitreous opacities for Weiss
Yes,
rings. So
absolutely.
there'd be all of these false positive Weiss rings that I would be diagnosing, and I
Absolutely.
and I think that as the years have gone by, I've gotten a little bit better at that. But our trainees, our residents, who uh, who hopefully can learn this method, it would be nice for them to have a supplemental technique that they can
Yes.
use beyond just the Weiss ring so that they can get a little bit more accuracy. And then, you and I, we look at the vitreous all day long. How many eyes are we looking at every single day?
Hmm.
But a comprehensive ophthalmologist or an optometrist who may not be as attuned to vitreous anatomy. They don't sort of know what it looks like and feels like intraoperatively.
Hmm.
Having a different method for them as well, I think, will be uh, even more impactful than it might be
Yeah.
for us.
Absolutely. I think your article also brings the attention to the OCT. I mean, you had a very nice, maybe expanded OCT method, but it also tells people you can actually use the OCT. And I tell my residents, look at the OCT. If you see the posterior highlight phase on the retina, there's no PVD. So if person's complaining about fluorescence flashes, look for another cause, or maybe it's a different cause. Um, and the Weiss ring is
Hmm.
one method. That Slit-Lamp is one method. So really affirming there is PVD, there is no PVD. I think you bring attention to two very seldom taught methods of asserting there's a PVD or not. One is the OCT, one is the method you just described. So,
Yeah, absolutely. You find, I think, in the clinic, you're actually using more than one method and sort of integrating
yes,
all that data.
100% agree. Wonderful, wonderful. Well, Dr. Ali, thank you very much. This was wonderful. I think I hope people listen to this podcast episode and read your articles, and this really wonderful piece of information gets disseminated so people learn more about it. Because whoever I teach this gets it, they get bewildered. Oh, how come no one taught me this before?
Yeah, yeah, that's the hope that hopefully we'll have more and more
Yeah,
people teaching this
yeah,
to others. There's
yeah.
one very important caveat that I wanted to mention because I didn't want people to be misled. And
Hmm.
this is something that we're working on now actively in trying to elucidate a little bit more. But uh, it's very important to recognize the limitations of this
Hmm.
technique. So,
Hmm.
one very important limitation, in my opinion, is that if you have a very fresh, acute posterior vitreous detachment,
Hmm.
meaning patient just developed symptoms this morning or yesterday or whatever the case may be, that posterior vitreous cortex just separated from the optic nerve head and still
Hmm.
may be very posterior. So posterior that you may not be able to identify the posterior hyaloid membrane in the setting of a very acute PVD.
Hmm.
When you start noticing it after an acute PVD is the subject of our next study.
Interesting.
It so that's something I want to convey that in the setting of an acute PVD, don't necessarily rely only on this technique.
Okay.
And then the second thing to mention is that, you know, uh, again, don't rely solely on this technique. If you have a patient who has otherwise significant symptoms of a PVD, you still have to do the full examination, scleral depressed,
Yes.
dilated fundus examination, even if you do not see the posterior hyaloid membrane method. So I just wanted to make sure that um, I conveyed that so that we don't end up, misleading people.
No, for sure. I think this is one tool in our toolbox. It's not the
Hmm.
only thing we rely on. It's a
Yeah.
wonderful tool, and thank you for mentioning this caveat, which I actually never thought about, but I should pay more attention to myself. So thank you.
Absolutely.
Well, thank you, Dr. Ali, for coming to Retina Channel podcast. This was a wonderful discussion, and thank you for publishing this great work and doing the work. Sounds like you're still busy doing more work on this, so I'm looking forward to more work from you. This is
My
great.
pleasure. Thank you so much for having me and for a chance to talk with you and to learn from you. So thank you.
Awesome. Thank you very much.
Mhm.
Have a good night.
All right. Good night. Bye bye.
Bye. All right, folks, this wraps up episode 93 of the Retina Channel podcast. Thank you for listening to this episode. I want to thank Dr. Ali for coming to the show and discussing his very interesting article on clinical diagnosis of posterior vitreous detachment without using condensing lenses. Well, a bit of a heads up about our next episode. We are moving east. Our next guest will be from Seoul, Korea. Will be Dr. On, Seong Jun On from Seoul, and he will be talking about his recent publication in JAMA Ophthalmology on systemic drugs and their association with maculopathy. It will be a nice world tour of different drugs and their maculopathy associations. And I'm very thankful Dr. On has accepted my invitation. He will be the first guest from Korea to come to Retina Channel podcast, and I look forward to that conversation as well. Well, until then, you guys take care, and until the new year, have a wonderful, wonderful holiday season. Bye bye.